Welcome back to this next video in which we are discussing kidney disease. Okay, so we're currently in the process of discussing the causes of acute kidney injury, and specifically we're looking at the intrarenal causes of acute kidney injury. And in the previous video we spent a long period of time discussing glomerulonephritis, a rare but serious cause of intrarenal acute kidney injury. In this video, what we're going to move on to is discussing the two other causes of intrarenal acute kidney injury, namely interstitial nephritis and tubular necrosis, and then we'll move on and discuss post-renal causes of acute kidney injury. So, let's begin then with interstitial nephritis, and you'll be relieved to know that there's much less to say about interstitial nephritis and tubular necrosis compared to glomerulonephritis. So firstly, what is interstitial nephritis? So let's just look at the words firstly. Interstitial means pertaining to the interstitium. The renal interstitium, the interstitium of the kidneys, is the tissue in between the nephrons. So in between the nephrons there is connective tissue and capillaries present. That is what we mean by the interstitium. Nephritis means inflammation of the kidneys, so interstitial nephritis means inflammation of the interstitium of the kidneys. Now, we'll come on to possible causes of this in a moment, but why is this capable of producing an acute kidney injury? Because, of course, the interstitium isn't actually the important bit as far as renal function is concerned. The nephrons are the important bit. So how is inflammation in the interstitium going to impact the nephrons? Well, we believe the explanation for this is possibly similar to the explanation for sepsis-induced AKI. So I'll remind you, when we discussed sepsis-induced AKI, we said that it's speculated that the reason is that the cytokine storm that is present within sepsis alters the behaviour of the renal tubule cells catastrophically and results in potentially their cilia not functioning correctly, and therefore the fluid that's within the lumens of the nephron not being moved correctly. If that occurs to enough nephrons, of course, it's going to lead to a significant drop in renal function and therefore an acute kidney injury. So possibly then, if you've got inflammation occurring in the interstitium of the kidneys, that's a local inflammation, that's going to also be releasing local inflammatory cytokines, and possibly then these local inflammatory cytokines produced by the interstitium are then able to have that same interfering effect on the renal tubule cells and therefore cause the renal tubule cells to misfunction. And if that occurs to enough nephrons, it'll lead to a significant drop in renal function and therefore an acute kidney injury. So that's the possible school of thought for how interstitial nephritis leads to an acute kidney injury. Let's now talk about causes of interstitial nephritis then. So there are two major categories, which are infections in the interstitium of the kidneys, and we'll talk about which infections in a moment, and then also iatrogenic causes. We don't understand this very well, but certain drugs can, in some people, unfortunately cause this interstitial nephritis, inflammation of the interstitium of the kidneys, and we don't really understand why. We don't understand why it occurs in only some people and why it occurs at all, but it is an acknowledged fact that this is a consequence of certain drugs in certain people. So, let's discuss this in a little bit more detail. Infections then, firstly, of the renal interstitium. There are two main ones to be aware of. So the first one to be aware of is tuberculosis, TB. So tuberculosis usually starts as an infection of the lungs, an infection of the lung tissue. However, in extremely severe disease, you can get disseminated tuberculosis, where it goes into the bloodstream and then disseminates all around the body. And one of the places it can end up is in the interstitium of the kidneys, and that can lead then to interstitial nephritis. So be aware of disseminated tuberculosis as a cause of interstitial nephritis. More likely, it's going to be an infection that actually started in the kidneys. So pyelonephritis can turn into interstitial nephritis. So let me just explain what pyelonephritis is. So pyelonephritis is also called an upper urinary tract infection or an upper UTI. And this is where you get an infection in the renal pelvis of the kidneys, so the place where the urine from the kidney tissue drains into before it then empties into the ureter to go down to the bladder and be stored. UTIs are very common, but usually they are lower UTIs and they're affecting the bladder and the urethra rather than upper UTIs, which affect the ureter and the renal pelvis. However, upper UTIs do happen, and they are infections generally of the gastrointestinal commensals, so E. coli and species that are commensals in the gastrointestinal tract. When they get into the urinary tract, that's when you get urinary tract infections. And if they track all the way up to the upper portions of the urinary tract, the renal pelvis, that's when we call it pyelonephritis. And pyelonephritis, if it doesn't get better or if it isn't treated, the infection can then end up in the interstitium of the kidneys and cause interstitial nephritis. So this would be a very serious consequence of pyelonephritis. So those are the two major infections to be aware of: disseminated tuberculosis and pyelonephritis. Drugs that can cause interstitial nephritis. I'll give you 4 categories of drugs that are the main ones that are associated with this. So 2 categories of antibiotics first. Penicillin antibiotics, a massive category of antibiotics, so penicillins. And the other category of antibiotics is cephalosporins, another category within the beta-lactam family. So cephalosporins, so they work in the same way as penicillins, but they don't have the same structure as penicillins. They have a slightly different variant of the beta-lactam structure. So cephalosporins, penicillins, massive categories of antibiotics that we use all the time in clinical medicine. Other drugs, non-steroidal anti-inflammatory drugs, NSAIDs, can cause this. So things like ibuprofen, aspirin, naproxen, diclofenac, they can give rise to this. And of course, in many countries, ibuprofen and aspirin are over-the-counter drugs, so it's quite scary that they, as a possible horrendous adverse effect, can lead to this inflammation of the renal interstitium. Be aware that paracetamol is not a non-steroidal. Its mechanism is believed to be similar but very different, crucially different to the other non-steroidals. So non-steroidals, and then finally diuretics, so drugs that increase fluid excretion by the kidneys, so things like the loop diuretics, furosemide, bumetanide, and the thiazide diuretics, benzoyl-flumothiazide and indapamide, which is a thiazide-like diuretic. These can give rise to interstitial nephritis as well. So be aware of these 4 categories of drugs: penicillins, cephalosporins, non-steroidals, and diuretics that potentially can cause iatrogenic interstitial nephritis. Okay, so let's now move on to tubular necrosis. So as I said when we first started discussing the causes of acute kidney injury, tubular necrosis is actually, of all the intrarenal causes of acute kidney injury, this is the most common. Now, necrosis means death of the cells, so tubular necrosis means death of tubular cells. However, tubular necrosis means more broadly damage to the renal cells. So we are doing something that is going to hugely damage the renal tubular cell function and maybe even actually kill them. And there are 2 major categories. We split tubular necrosis into 2 major categories, and I'll come down, let's say, to here to do this. So tubular necrosis, we can split it up into nephrotoxic tubular necrosis, and this again is drug-induced, so drugs that directly have effects on renal tubular cells and impair their function. And again, when we impair the function, when the renal tubular cells misfunction, of course their cilia aren't going to work correctly, and that's how the amount of fluid being moved through the renal tubules is going to decrease, and therefore nephron function is going to deteriorate. And if enough nephrons are being affected, that will significantly impair renal function. So nephrotoxic is one category, and ischemic is the other category, so lack of blood flow. So let me discuss this in more detail. So again, bear in mind that although we call this tubular necrosis, it's broader than that. It's not necessarily the cells actually having to die. It might also just be the cells hugely misfunctioning because they've incurred some massive insult, and this insult is separate to the cytokine-mediated misfunction that we've talked about in sepsis-induced AKI or interstitial nephritis. So, nephrotoxic agents then, so these are drugs that we know damage renal tubular cells. Renal tubular cells do not like them. These drugs, if you expose renal tubular cells to them, will make the renal tubular cells misfunction and potentially even kill them. So there are 3 major drugs that I'm going to give you here, or 3 major categories. So, whoops, that's not what I wanted to write. So the first is another category of antibiotics, aminoglycosides. So these are an old category of antibiotics, and they're a bit of a scary category of antibiotics. They can cause scary side effects such as this nephrotoxic effect, but they're also ototoxic. They have nasty effects up in the ears as well, and can damage the cells that are crucial for transducing auditory stimuli into neurological phenomena, and therefore can lead to hearing loss. So aminoglycosides, they're quite a dirty class of drugs. However, we do still use them. Gentamicin is the big one that we still use because it's such a powerful antibiotic. They are very, very good antibiotics, particularly at killing gram-negative bacteria. Tobramycin is the other one that is commonly still used. In particular, it has a use in children and young adults with cystic fibrosis who have got horrendous pseudomonal infections of the respiratory tract. Tobramycin will be given because of its powerful anti-pseudomonal effect, because killing Pseudomonas is quite difficult. There are very few antibiotics that work, but aminoglycosides are generally very good. So this is an old category of antibiotics that is still used. It's a bit of a dirty class of drugs because we know it impairs the kidneys and it hits the ears as well, the auditory transducing system. Other drugs that we know have nephrotoxic effects. Metformin is also recognised to have a nephrotoxic effect. This drug is given commonly in type 2 diabetes, and it reduces the amount of glucose that the liver is releasing into the bloodstream, and therefore helps to bring down fasting blood glucose in people with insulin resistance, as in type 2 diabetes. But it is recognised that in some people it will have a nephrotoxic effect. Finally, the other big one to be aware of is lithium. Lithium is used to treat bipolar disorder. It's a mood stabilizer. It helps to stop manic episodes and also stop depressive episodes in bipolar disorder. Again, it's recognized that it has a nephrotoxic effect. It impairs the function of the renal tubules and can result in renal tubular cells dying. Now, be aware that even if you've had a nephrotoxic tubular necrosis, so let's say lots of renal cells have died because of exposure to one of these agents, let's say gentamicin, that doesn't necessarily lead to chronic kidney disease. You might think if lots of the renal tubular cells have died, surely that's going to lead to permanent loss of that nephron and therefore chronic kidney disease. However, the nephrons do have an ability to heal. As long as the damage is not too bad, then the renal tubular cells may be able to be replaced and the nephron may be able to heal. So be aware that even though tubular cells are dying, it doesn't necessarily mean we're going to cause CKD. It might just be an acute kidney injury and the nephrons may heal. Of course, if it's bad enough for tubular necrosis, then yes, renal tubular cells will be damaged so many renal tubular cells will be damaged that the whole nephron will never be the same again and will be replaced by scar tissue, and then you're looking at a CKD picture. So of course this can lead to CKD. Also be aware that interstitial nephritis, it can also lead to CKD. I mean, if the inflammation is bad enough in the interstitium, of course it's going to lead to damage to those nephrons and potentially replacement by scar tissue and therefore CKD. So all of these different causes that we're talking about here, these intrarenal causes of acute kidney injury, if they're bad enough, they will lead to a CKD picture, not just an AKI picture. But more about that when we come on to CKD. Ischemic causes then of tubular necrosis. So ischemic means lack of blood supply, not enough blood supply to meet the oxygen demands of the tissue. So of course, renal tissue is living tissue as well. It needs to have a blood supply in order to supply the cells of the nephrons with oxygen to keep them respiring. If you don't respire, you expire. So if blood flow isn't great enough to renal tissue, again, renal tissue will die. Renal tubular cells will necrose. So this is another cause of tubular necrosis. And again, depending on how bad the extent of the tubular necrosis is, will determine whether you get an AKI picture or whether it's going to transform into a CKD picture, i.e. whether the nephrons are damaged beyond repair, in which case it will be CKD, or if they're damaged to some extent but it can be repaired, in which case it will be an AKI. Also be aware that it might just lead to a renal misfunction. The ischemia might not be bad enough to actually kill the cells, they might just start misfunctioning, and that would also give rise to an AKI because their cilia aren't operating correctly. So, causes of ischemic tubular necrosis then. So, shock is one of the big ones. So, shock in the medical sense means blood pressure becoming far too low, critically low, and therefore tissues not being supplied with adequate perfusion. So this is a systemic disease, a systemic phenomenon, and it will be impacting all sorts of tissues. And there are loads of different causes of shock. There's septic shock, where sepsis gets so bad that blood pressure starts to collapse. There's anaphylactic shock, where an allergic reaction causes widespread vasodilatation and therefore blood pressure collapses. And there are other forms, cardiogenic shock, where the heart isn't beating correctly and therefore can't maintain blood pressure. Occlusive shock, which is things like massive PEs or cardiac tamponade that is physically occluding the ability of blood to be circulated around the body. So there are loads of different causes of shock. The important thing for you to understand is that if blood pressure is too low for a long period of time, that will decrease renal perfusion acutely, and you may well get tubular necrosis as a result of that. That will give a lasting AKI, or if it's bad enough, a lasting CKD picture. The other thing to be aware of is thromboembolic disease as well. This could also lead to ischemia of the kidneys, so thromboembolic disease. So of course, the kidneys have an arterial supply. If either a thrombus forms in an artery or an embolus gets stuck in an artery, that is going to occlude blood flow to the downstream tissue, and that tissue will start to undergo tubular necrosis. Again, depending on how bad the ischemia is, and depending on how long it goes on for, you'll either get an AKI picture or a CKD picture. So be aware of those two as causes for ischemic tubular necrosis. So, tubular necrosis is a major cause of intrarenal acute kidney injury, the main one to know about. And if someone does have an AKI, you need to consider stopping these drugs if they are on any of them, because it could be a tubular necrosis picture. In addition, you would want to stop drugs that could potentially cause interstitial nephritis picture in a patient who has an AKI, just in case these are the cause, unless of course you're aware of a different cause being there. Of course, if you know they've got sepsis and you think the AKI is sepsis-induced AKI, you would not stop antibiotics, because the antibiotics are what's going to make them better. It's only if you suspect one of these other causes, either nephrotoxic tubular necrosis or interstitial nephritis, you need to stop these certain drugs. Right, so that's intrarenal acute kidney injury now covered. Let's now move on then and discuss post-renal acute kidney injury. So this is all about the urinary tract after the kidneys, so about the ureter and the bladder and the urethra. Now, if part of the urinary tract downstream of the kidneys becomes obstructed, what can happen is urine then backs up the ureter and into the renal pelvis, and the whole thing swells and fills up with urine. Now, of course, if all of that draining system is filled up with urine, the kidneys cannot keep on producing urine because there's nowhere for it to go, so the whole thing can then shut down. Now, there is a name for this backing up of urine up the ureter and into the renal pelvis, and it is called hydronephrosis. So hydronephrosis is the cause of post-renal acute kidney injury. So I'll say that again. Hydronephrosis is where urine is going to back up in the ureter, so there's some sort of obstruction, urine backs up in the ureter, the whole ureter dilates because it's so full of urine, the renal pelvis dilates, it's so full of urine, and that pressure is going to stop the nephrons from being able to produce any more urine because simply there's nowhere for it to go. And the nephrons on that kidney, if it's just unilateral, then it will be only one kidney affected. If it's bilateral hydronephrosis, then both kidneys will be affected. Of course, all the nephrons in the kidneys that are affected by hydronephrosis are going to shut down their function, and therefore an acute kidney injury will occur. And it's an acute kidney injury because if you reverse the hydronephrosis, then the kidney function can be restored. If the hydronephrosis is present for a long period of time, then it may lead to permanent damage to the renal tubules and loss of renal tubules, and therefore a CKD picture may emerge from hydronephrosis. So what are the different causes then for hydronephrosis? So all the different things that could possibly occlude the urinary tract. So start with the ureters. What can occlude the ureters? Well, the classic thing is renal stones. Nephrolithiasis is the proper name for renal stones. So renal stones are quite common, and they form in the renal pelvis. And unfortunately, they can dislodge from the renal pelvis and end up going down the ureters. They form from different things. There are different types of renal stones that form from different things that are present within the urine. When they dislodge from the renal pelvis and go down the ureters, they can then get stuck in the ureters, and this causes a phenomenal amount of pain, but it can also then block the ureter, and urine can then back up the ureter into the renal pelvis, and then you've got hydronephrosis. So renal stones is a cause for hydronephrosis, and that would be a unilateral hydronephrosis that you would get if it got stuck in the ureter. However, it could go further down, possibly, into the bladder and then get stuck in the urethra. That's much rarer, but if it did get stuck in the urethra, that could then give rise to the bladder filling up with urine and both ureters then filling up with urine and becoming backlogged, in which case you would get bilateral hydronephrosis. So renal stones can block the urinary tract. Tumours can also block the urinary tract. So tumours of the bladder and tumours of the prostate in men are the two main ones that you would worry about. So tumours of the bladder can either grow over the entrance to the bladder from the ureters, in which case they would block one of the ureters and cause unilateral hydronephrosis, or they could grow over the exit from the bladder into the urethra, and then they will cause the whole bladder to swell up with urine, and they will cause bilateral hydronephrosis. So bladder tumours are an important potential cause of post-renal acute kidney injury. Prostate tumours, again, that will obstruct the urethra, and therefore you'll get the bladder filling up with urine, and bilateral hydronephrosis will ensue. Moreover, tumours anywhere within the abdominal cavity, from any organ in the abdominal cavity, can potentially press on one of the ureters, and therefore could lead to unilateral hydronephrosis and an acute kidney injury. So tumours are a big cause of obstruction to the urinary tract. Finally, in men, there is a condition known as benign prostatic hyperplasia, BPH for short, and this is enlargement of the prostate. It's an idiopathic enlargement of the prostate, and it occurs in nearly all men as they get older. Now, the problem with it is it can occlude the prostatic urethra, the portion of the urethra that runs through the prostate, and this can get so bad that it completely prevents urine from being able to exit the urinary bladder. And in that case, of course, the urinary bladder will swell and you'll get bilateral hydronephrosis. So all of these different things, obstructions to the urinary tract, can lead to either unilateral or bilateral hydronephrosis, and that will lead to a massive drop in renal function if it occurs, particularly if it's bilateral, of course. And it's quite simply a mechanics thing. The nephrons cannot just keep producing urine if there's nowhere for it to go. The whole system just backlogs and has to stop working. So that's post-renal cause of acute kidney injury. Before we have another break, let me just summarise what we have seen about nephrotic syndrome. So we've now finished acute kidney injury. We've talked about all the main causes of acute kidney injury, the pre-renal, the intrarenal and the post-renal. However, we actually have also, through that discussion, done nephrotic syndrome as well, because all the causes for nephrotic syndrome were brought up in the discussion that we've just had, or all the main causes of nephrotic syndrome were brought up in the discussion that we've had. So glomerulonephritis is the cause of nephrotic syndrome. Inflammation of the glomerular basement membrane is obviously what is going to have to happen in order for you to end up with holes in the glomerular basement membrane to allow albumin to leak out, which is the crucial part in the pathogenesis of nephrotic syndrome. So let me just summarise what we've learned about nephrotic syndrome here, and in the next video we'll go on to discuss CKD and renal hypoperfusion that go together as well, just like nephrotic syndrome and acute kidney injury go together. So, we saw minimal change disease, this idiopathic inflammation of the glomerular basement membrane that classically results in nephrotic syndrome and usually not in acute kidney injury. However, it's not unheard of for it to cause an acute kidney injury. And remember, that's the one where if you look at it histologically, you see minimal change. We also saw focal segmental glomerulosclerosis, which also classically presents as nephrotic syndrome and very, very rarely would ever cause acute kidney injury. Remember, that's associated with HIV and heroin, and you get focal segments of the kidneys undergoing glomerulosclerosis. All the other causes of glomerulonephritis that we looked at, so in that categorization, type 1, type 2, type 3, they can also lead to nephrotic syndrome, but they are much more likely than these first two causes to actually lead to an acute kidney injury. They can also lead to the nephritic picture, where the damage to the basement membrane is so bad that actually red blood cells can escape into the glomerular filtrate, and therefore you can get hematuria in their presence. So I'm just putting this here, all other forms of glomerulonephritis. So in fact, I could have simplified this much easier by saying that actually it's just glomerulonephritis that is the major cause of nephrotic syndrome. Just be aware that these two are the ones that primarily present with nephrotic syndrome, whereas these other causes, they will primarily present with a acute kidney injury. They may have on the side a nephrotic syndrome or even a nephritic picture. Okay, so we'll have a break there, and in the next video we'll move on to the causes of CKD, and along with that we'll discuss this renal hypoperfusion syndrome that I mentioned at the start.